Hello, everyone. Welcome to Facility Compliance Think Tank. My name is Lance Woolf, and I'll be your moderator for today's webinar. And this is the third webinar in a series of 5 this fall. Today's subject is how to maintain healthcare facilities with limited resources. Facilities Compliance Think Tank, or FCTT for short, this whole venture was created and sponsored by Soleran since COVID-19 has caused such an impact within hospitals. So it's canceled educational conventions and opportunities. So what we've done is we've handpicked the nation's top professionals in their field to help with compliance. The webinar has 2 purposes. First, we want to discuss best practices in the areas of life safety, emergency preparedness, and other compliance-related topics during COVID. And second is this series of webinars was created to help healthcare professionals network together and share ideas amongst each other. We want you to take those best practices and build upon them, which helps all professionals nationwide. Our members consist of directors and facility compliance leaders all over the country, and they focus on real-time practices throughout this webinar series. We also have a couple additional resources for you, and that includes one is we have a leadership networking group that's located on LinkedIn, and 2, we've got an online Q&A on Soleran's website for any type of compliance questions that you may have. A little bit of background on me. Again, my name is Lance Woolf, and I'm the Director of Life Safety Compliance here at Soleran. I'm a former life safety code surveyor for Joint Commission, and I have 17 years experience in hospitals at the director, senior director position level. Areas that I oversaw was engineering, emergency preparedness, safety, biomed, security, and environmental services. So during these 17 years, I also dealt with H1N1, SARS, Ebola, and now COVID-19. A little bit about today's speaker lineup is first we have Jason Piper. He's the Administrative Director of Planning, Design, and Construction at Advent Health, located in Kansas City, Missouri. And then next we have Damion Schinnerer. He's AVP BioMed Engineer at Wellstar Health System, located in Marietta, Georgia. And then we have Jeff Lehmann. He's the President at Medical Compliance Team, and he's located in Portage, Michigan. So we appreciate all of our speakers taking their time out of their day today to provide us with a wealth of knowledge on these different topics. And I'm sure it's going to be informative for everyone here. A little bit of housekeeping items is each panelist is going to have about 5 minutes to utilize their PowerPoint slides, but we encourage you take screenshots. But if you miss it, we're going to be recording the webinar, and it's going to be emailed to you tomorrow in case you missed something. So feel free to use this webinar as a reference. After our speakers are presented, we're going to have about 10 minutes for a live Q&A session. And so please use the Q&A button at the bottom of your screen to ask your questions. Don't use the chat, use the Q&A button. And if your toolbar, it's going to reappear. We're going to try to get to as many questions as possible, and we're going to follow up with you if yours isn't answered during the webinar. Now, any questions afterwards, utilize the Think Tank Q&A online where FCTT members can interact and answer your questions. And that's going to be our last slide of the presentation. We're going to have that web address on it so you can utilize the slide. Well, we're going to go ahead and get started on the webinar, and we're going to begin with Jason. Jason, are you there?
Yes, I am, Lance. I'm here.
Great, Jason. Well, we're glad to have you here, and go ahead and take it away for us.
I appreciate it. Thanks, Lance, and thank you to Soleran for hosting us. That's pretty excited to be part of this today. So appreciate you guys stepping up and trying to help the community through this, through our pandemic, and still get us the education that we need. So appreciate that. So guys, I'm here to talk about 2 things today: strategies for helping justify staffing and justifying square footage and PMs completed. So if this was 2019, I'd be sitting here talking to you about how with the Medicare reimbursables, how healthcare is expensive. We got to keep costs down, to where I'd be talking about as far as trying to justify keeping staff, or because as we all know, we have those struggles. We got to stay competitive, and they always seem to look to support staff to think they're expendable a bit. So, but I'm not here to talk about that as far as when it's the Medicaid, Medicare. I'm here to talk about as far as what we had to deal with COVID, and trying to also justify staffing and keep up with our compliance. So how we started is the months of January and February, we actually had Deloitte in here And they were talking through with us. So basically, if you guys saw Office Space, I was with the two Bobs for about 2 months and just finished doing all my data collection, square footage justifications, and I turned that in at the probably around the first week of February. So we were all paying attention to the news, everything was going, and then we started to hear stuff about the COVID a little bit more and more. So we actually stood up incident command. Our first incident command was on the 29th of February. And that was simply just to discuss some returning doctors that were out of country. They're on a mission trip. So there was 8 of us. I was part of the incident command. I was in charge of logistics and supply chain. So we kind of came in and just had a little chat, and there was one individual was saying, he goes, man, I will be surprised if we even have one patient. So we all know that's far from the case. At first, we really weren't taking it serious, but then by the 3rd week of March, we stopped doing elective surgeries. So with that, it caused a mass redeployment. Basically, what we were looking at is right around 620 employees with the deletion of elective surgeries. So had to do a mass redeployment. We ended up classifying essential and not essential employees. 160 of those employees stayed home and just worked from home, or some of them really couldn't do their job, so they just kind of stayed home and got a nice little vacation. Then with the essential employees, there was 360 of those, and we redeployed those. So it was a big help in that aspect as far as redeployment. I'll kind of talk more on that on my next slide, but trying to reassign to those people, kind of, you got a bunch of nurses and techs that are used to being in the surgery environment. So now they're in the facilities environment, they're in the finance environment, they're in the food service environment. So it was a big team effort. But also in that aspect where with facility staff, I had to look to outside services for that, hiring of mechanical and electrical contractors, because during that, we ended up having 3 essential staff members of the facilities department decided to retire. It was, hey man, I think it's going to be safer if I just stay home. So they gave us their 3-day notice and off into the sunset they went. So couldn't hold any hard feelings on that. Had a lot of experience there between those 3 employees. I lost roughly around 125 years of experience between those 3. So it was something to deal with. So then with the redeployment, we had things that we had to get in touch with as far as with the screening stations. We allowed getting staff in. We still had to scan for those people. So we used a lot of those people to redeploy to kind of help with our screening stations. And as we all know, that requirement to that changed on a daily basis to where the 6 feet, people wearing masks, do you not wear masks? What's the temperature rating, the symptoms? What were as far as the hot buttons, as far as where they travel to. So redeployment helped in that. And then we also had a thing with the testing locations. We were a major testing site for the KC metro area. And we had some outlying clinics that we were trying to do our testing for. And what it came down to was people would drive by, they saw one of our campuses that we had throughout the city and saw that there was a line. So they automatically just drove in line and started thinking they could just get a free COVID test. So as we all know, man, you have to have orders for that. It's got to have a doctor's order. So we redeployed in just traffic management to the 3 clinics that we were doing that at. I redeployed 35 individuals that were nurses, various modalities throughout the hospital that helped with that. So interesting time. They basically became traffic control. So adaptability was 100%. So could we have next slide, please? So with that being said, why this is going on, we also had to keep up with the compliance. And not sure if all you guys know, but Joint Commission halfway through, and I think Lance and Jeff will kind of speak to it a little bit further, they were issued a waiver. And that waiver is great as far as having low staff to be able to keep up with your compliance. Problem is that that waiver is eventually going to run out. So we made a major stronghold, and we did not lack on our compliance. We had smaller numbers. We still did our EOC rounding. We still did our safety walks. We kept up with our paperwork. Had to work with contractors. Some contractors didn't want to come into the hospital. And some of them we had to bring into the hospital because they already had our service contracts. So we kind of had to work through the legality of that to be able to provide the services that we need so we can keep our patients and staff safe during that time. So during this thing, talking about compliance, we were in the window at our 2 surgery centers for a joint commission. So with the cancellation of basically a joint commission said, guys, we're not going to inspect. You guys keep focusing on your patients. We'll get to you when we can get to you. So the cancellation of elective surgeries kind of made something unique that in my 18 years of healthcare I never had. I had full access to ORs. ORs, central processing with, we were doing surgeries, but they were on emergency type. So as far as the traffic that goes on in the ORs was minimal. So I was able to get in there, perform PM, switch out smoke dampers, do everything that would be virtually at night, outrageously expensive, quick, to where I had about 2.5 months to where I could get in there and fully do what I needed to do in the ORs, which would have been a scheduling nightmare, not the pandemic hit. So the one positive thing I can say about the pandemic is it helped us keep up with our compliance in our ORs on areas that we really weren't able to get into in a normal state. So another unique, as far as in closing, we redeployed staff in the facilities department. We had nurses with paintbrushes. We had them help with the EOC rounding. We have the Soleran app to where we're doing our environmental care walks. Gave them the pads, they're walking around. So one thing that we did notice is we tried to get a nurse and we found out what floor they were on, and then we sent them to another floor because basically once you gave them the pad and they realized what they could do, our laundry list got pretty extensive because they were able to, the honey to do list as far as everything that they knew was wrong, they just put on. So kind of work order wise, had to sort through that. But all in all, it was a team effort. We got together and kind of made it through as a team. And as far as we have, once we're in the window at our main hospital and still our 2 OR and our 2 surgery centers. So I feel pretty confident that we're in a good spot. So I'm going to be doing some mock surveying with some outside sources. Looking forward to that. So all in all, it was a team effort. So Lance, that's all I got.
Great. Well, thanks, Jason. I really appreciate it. That was a lot of information, and it was some excellent ideas on how to be able to utilize those limited resources. So thank you again. So now we're going to go ahead and move to Damion. And since many engineering departments also have such a close relationship where they oversee biomed areas as well, we have Damion on this webinar to help us with current biomed strategies with limited resources, that he's utilizing within his facility. So Damion, looks like you're there. Are you ready to go?
Ready to go. Thanks for the introduction and the opportunity to speak today on this.
Okay, and just a side note, I apologize. Damion right now, he's dealing with Hurricane Zeta. In case we lose him, that would be the reason for him. But let's hope we can get you through your presentation today.
I've already knocked on some wood, so let's go.
Okay.
Next slide, please. All right. So obviously in the biomed world, I know that AEM is prevalent, and some organizations have very strong AEM programs, and other organizations are trying to avoid it. Realistically, everybody has an AEM program, whether they know it or not. Anytime you deviate from the manufacturer's literature, whether it's a part number, so if you use a third-party vendor potentially for a battery that you source from an alternative source, you're technically deviating from the manufacturer's literature. Or if it's a piece of test equipment that's clearly defined and doesn't say or similar device, which a lot of them have been improving on, that would require a AEM as well. The thing that's very important about understanding AEM, and the reason why defensible is the primary target here, is it takes quite a bit of work on the front end in order to have an appropriate AEM program in place for the safety of the patients and for the inspections that may come, DNV or joint. I've personally been through about 57 DNV and joint inspections with an AEM program with 0 write-ups associated, mainly due to the paperwork and the due diligence on the front end. Next slide, please. Probability of failure, also known as a risk assessment. Ideally, you want to kind of be able to have a database that you can pull very, how do I want to say, very clean data, quality data that you can sort and filter in a relatively quick time frame. Normally, I would divide it up by nomenclature. Obviously, all digital thermometers, all digital oral thermometers would be categorized as a single nomenclature, do a risk assessment, identifying the serious impact if it were to malfunction, and then also utilizing PCR codes, which I'll touch on in just a little bit, to determine the reason for failure. So when you kind of combine this data, generally you'd want to have a little bit of history to be able to appropriately defend your defensible AEM. Next slide, please. Maintenance history. This is kind of what I was leaning on with the historical data. Now, some hospital organizations have many hospitals across an organization that they can rely on their sister facilities for some of their historical data to justify that. For those of you in a smaller hospital organization or not with a larger group, ICRI and AMI also has resources available for you to pull up data to help justify a AEM program on a newer device. Say you just switched your infusion pumps. I'll say the Plum 360s have been out for quite a few years, but you may not have had them in your organization. AMI, ICRI would also be able to provide that data to help you determine if those devices would be right for an AEM program. Next slide, please. PCR codes, and I can't state this enough. It is, I almost want to say impeccable, but that's not true. It's vital that you have PCR codes available in your database. If you do not have a quality database, it is going to be almost impossible to have a defensible AEM program. The PCR codes allow you to make quick work of those risk assessments. First, by the problem. I know all of us are very used to receiving devices or work orders that says broken, but in this instance, we would be able to, the technicians, determine that it was a power issue. The cause, we'll say that the power cable was ran over by a stretcher in the OR. And then the resolution would generally be replaced, damaged part, returned back to service. Now, based upon that PCR code, there was nothing I could do from a preventive maintenance standpoint to prevent that from failing. However, if I determined that I wanted to make a IV pump every 24 months for a battery replacement rather than every 12 months for a battery replacement, if that device failed prior to that 24-month period, my cause would state PM preventable. PM preventable is one of those that we would tend to search and basically pull everything up associated to PM preventable. So if I failed to conduct what the manufacturer said and that led to a failure, that would then very clearly be associated to the risk assessment to determine if you're still good to go, or if those add up relatively quickly, if you need to adjust. Next slide, please. So ideally what this is you're trying to be predictive. You want to forecast downtime. Many PMs consist of verifications. We all know that when you verify something, you're not helping prevent that device from failing. For instance, there are many high-risk devices out there like ESUs and defibrillators that absolutely we would want to follow manufacturer's literature in regards to those because of such a high risk to the patient if that device were to fail. However, a thermometer, oral thermometer, for instance, if we perform a verification on it, the likelihood of us preventing that from failing a week down the road or 2 weeks down the road is very slim. Now, by all means, we could be super proactive and replace the batteries and the oral probe proactively before it failed, but that probe may have lasted another 2 years before being replaced. Probably not. Or that battery may have just been replaced by the nursing staff was there at the desk, and now we're just throwing away batteries and not being as cost effective as we would like. Next slide, please.
Well, great, Damion. Thank you again. Is there anything else you want to follow up with on a close-up statement?
Yeah, I just wanted to wrap up, and honestly, I thought there was one more slide in there, so I apologize. So overall, by being predictive and analyzing the data on a regular basis, there are opportunities for an organization to reduce the number of preventive work orders for your department. Now, I will say that it is very dependent on the data, not always dependent on your staff. So make sure that the data is driving that decision and not necessarily your staff. However, I bet you'll find there's opportunities to save money and manpower. Thank you, Lance.
Great, thank you, Damion. That was great information, and it was great that it came from a unique source that we don't come across every day with the biomed aspect. So thank you so much. That was great. So next, we're going to talk about issues identified with some limited resources and look at a surveyor's perspective. Next slide, please. So these are the issues that are being identified with limited resources. One is your surveyors they're identifying that the manufacturer guidelines are not being followed. And with that increased risk, you're increasing your patient's risk, due to lack of maintenance. So what's happening is you're prioritizing your maintenance, but unfortunately, with the limited resources, you're not getting enough resources to complete that maintenance schedule, which makes it tough for you. And the surveyor is going to focus on that. They're going to look for your major failures that are occurring due to lack of maintenance, and they're going to keep asking questions in regards to, budgetary increases, what's happening with your limited budget, and you're identifying as well that all these are increasing as a result because you're increasing your overtime, you're increasing your budget, but when you have that budget taken away and those limited resources, it's causing a lot of regulatory oversight that's being missed. So next slide, please. So these are some survey possibilities that you might come across. Is one, your surveyor is going to identify that you're working with limited staff, and they're going to start focusing on process issues. So the first thing they're going to focus on is your documentation. It's going to be scrutinized a lot. And then what they're looking for is you're going to be looking for oversight. So more time is going to be also spent in the engineering rooms evaluating equipment. And then what's going to happen is they're going to want to tie that equipment that they're identifying in the engineering rooms that they feel that maybe the maintenance schedule is not being complete. They're going to start requesting for PM program information. And they're going to also request to match up that PM with the manufacturer's recommendations. So what you're going to want to talk about is any variance you're going to need to be able to speak to as either an AEM or staff is able to speak to the changes in the maintenance schedule. As we talked about earlier, Jason Piper identified this as well. Many facilities right now, we have the 1135 waiver, so you have some adjustment. And so some facilities may choose to have that adjustment based upon those limited resources that you're having. Next slide, please. So these are some of the questions you may be asked. One, the surveyor is going to ask, what's the reason for your limited staff? Currently right now would be COVID. If it's outside of COVID, budgetary is the most common answer. And the reason why is because hospitals are constantly evaluating to look for opportunities to save costs. And unfortunately, in the non-clinical areas, those are the first areas that are focused upon. So as the engineering departments, go along, they're getting individuals taken away from them, which also it comes right down to it hits you in your areas of maintenance. Surveyor is going to ask, okay, with you working with limited resources, what other areas of the hospital that you feel has been affected? And they're going to go and look at that and focus on that during their physical survey. Also, they're going to ask, how are you managing the decrease in staff? Jason Piper used an excellent example of it. Are you looking outside the box? What are you doing to help solve this process? They're going to talk about, okay, how are you managing your vendors to help with time-specific maintenance? You know, your vendors might be dealing with limited resources as well. So what are you doing to help mitigate those? And what are your strategies to increase the budgetary or staff? The last question that they're probably going to answer is, have you had any equipment recently installed? And what they're going to focus on there is they're going to focus on, did you follow the process that is in place when you get a piece of equipment installed? Was it installed correctly? Did you test it before you brought it online? Did you make sure that everything maintenance wise and all the manufacturer recommendations were followed prior to that equipment being utilized on a daily basis? Next slide, please. So how do you prepare for that? Well, first, you're going to want to immediately identify your oversights. And then you're going to want to decide on your mitigation strategy and utilize exterior resources to help you with this. You know, don't take this on as yourself, because, you know, there's many different opinions. And so when you're thinking outside the box, there might be an area that you're missing. Also, track your labor that's needed for the equipment based upon your staffing hours. This helps with your justification for your future budgets coming up. It also helps with your justification. Currently, what's going on is that if you're taking people away and you have limited resources, you need to be able to show individuals up in the C-suite, hey, to be able to properly maintain this equipment, I need to have this many staffing hours based upon the manufacturer's recommendations. So use that to your advantage. Also, increase your digital automation possibilities to assist you in maintaining compliance. Have that check and balance system there to where it's automated, to where you're not having to follow up on a paper since you're working with limited resources. Utilize your staff experience to assist in identifying areas that can be operated differently to increase the efficiency. And this goes back to, you know, think outside the box and utilize your staff and their experience to help you identify other areas of opportunity. And then last, ask your surveyor to identify issues to administration on your behalf. At times when I was on a survey and I identified that they had limited resources, I felt that I should become the advocate for the engineering staff to help them increase their staff, because with regulatory oversight increasing, maintenance increasing, recommendations increasing, you know, with limited resources, you need to have somebody there, and especially with a surveyor that's been there in your shoes at one point. They're going to be that advocate for you to utilize it. Next slide, please. So now that's the end of my presentation. We're going to move on now to using your vendors to manage life safety documentation with Jeff Lehmann. And Jeff, are you there?
I am, Lance. Thank you.
Okay, Jeff. Well, thank you very much for being here today, and go ahead and take it away.
Okay, next slide, please. You know, a little bit about me. I own a company called Medical Compliance Team out of Kalamazoo, Michigan. We perform about 50% new construction compliance and about 50% compliance in the already built environment. In October of 2004, I went to the Joint Commission as one of the original 50 life safety code surveyors. I was kind of a guinea pig along with 49 of my friends, and we kind of started that life safety program. In 2012, I transitioned over to AAAHC and really live in that surgery center world now since 2012. I've spent 30 years on the streets as a police officer and a paramedic, and about 10 years working safety risk management for a large trauma center hospital world. Next slide. Possible solutions for working with fewer resources. So what I do in the surgery center world now is I partner with other vendors. So I have medical gas specialists, I have fire alarm and sprinkler vendors, I have biomed guys, and we all come together as one company and offer solutions to surgery centers and small hospitals for managing their inspections and tracking their paperwork. We utilize automation software to do it, and we use software to conduct inspections and identify deficiencies, and then those deficiencies are fixed or continually followed up until they're mitigated. Next slide. What is the problem? So when I was with the Joint Commission, one of the things that I would do during the document review session is I would scan through the documents, and I would look for the note section at the end. So a large fire alarm report with hundreds or even thousands of devices. It's hard to look at that complete report with the time that you have that the Joint Commission allotted you. So I would often skip to the note section, and that's where you would find all the deficiencies. I taught facility managers over the years that, the best thing that they could do not to miss deficiencies would use the yellow highlighter rule. So anytime a report came back from a vendor, it would be printed, and that facility manager would highlight the notes in that section to make sure they didn't miss things. But more times than not, we found that many deficiencies were missed, and it was clearly spelled out in the notes section at the end of the report. And the reason that happens is because a lot of times those reports don't come in for 2-3 weeks after the inspection is complete. It goes to an administrative assistant, and it really rarely makes it back to the department manager. The inspection technician turns, and I just mentioned that. And then lack of appropriate experience for the person reviewing the report is also important. Next slide. Next slide, please. Okay. Why is it a problem? Well, it takes significant resources and knowledge to create inventories of devices, select vendors, schedule inspections, and analyze the reports. I had 2 major hospital chains in the northern part of the United States that I went to every 3 years as a surveyor. And each time I went to those hospitals, they told me that they were going to do the complete document review session online in a SharePoint program. And I go, great. And I could ask for any report I wanted to for any of the buildings, and they would have that report in the SharePoint folder. So if you're scared of getting rid of binders and going to electronic media, don't be. It's completely up to you how you manage your data. You can manage your data in binders. You can manage your data online. You can use a SharePoint site. However you want to do it, the Joint Commission doesn't specify that. Now they're going to ask you in an emergency, power outage, hurricane, how you manage that information when you don't have internet access, and then you have to make a decision on what you're going to do. Another issue is that technicians often talk with the trades, and the information does not always get back to the department manager. So the fire alarm technician or the electrician that you have on staff will get a fire alarm report, and 3 or 4 AV devices have failed. That information doesn't always get back to the department manager, and sometimes doesn't get followed up on. Not all the time, but sometimes. And then where I'm living right now is the small healthcare organization, surgery centers, that it's the nurse manager, the CEO, the safety officer that's managing those reports. And they really have no experience with testing, inspection, and maintenance, and no knowledge of what the rules are regarding generators and testing fuel annually, and all those little things that get by them because they just don't know what's going on. Next slide. Here's an example of kind of how we do compliance. We first come in and inventory all the assets in the organization. We install a compliance board at the organization, and that compliance board has your life safety drawing in full color, your 1-line drawing of your electrical system, your NFPA 99 required risk assessment, are you a category 1, 2, 3, or 4 facility, and emergency contact information. And also new to this year is what the wet area risk assessments, right? Then we assign risk to all assets in the organization. We assign a frequency to all asset inspections. We determine if it's an AEM or an OEM program. And then we have 5 life safety code specialists that write the inspection criteria ahead of time. And I got this idea way back probably in 2006 or 2007 when I was surveying a hospital in Nebraska. And in the front of every binder, in front of every inspection, they had a full page example or narrative on what's required during the inspection of that asset. And I was so impressed with that I kind of lived with that and taken it back with me and used that in my inspections. We then inspect the assets. So we use one of our partner vendors, the fire alarm vendors, the sprinkler vendors, the generator specialists. We make sure that they're certified as high as they go or can go. And then we develop an affordable program with different frequencies. So we have surgery centers that we go to daily. We have some that we go to weekly. We have monthly contracts, and then we have quarterly contracts for about 20, 25 centers across the country. Next slide. Okay, so that's kind of what we do and how we utilize software and how do we conduct the inspections. Thank you, Lance.
Great. Thank you, Jeff. I appreciate your time and really appreciate, the amount of background that you have that you're able to bring along, especially with Joint Commission. I know that's been helpful for everybody that's been on the webinars. So we've covered a lot of information. We're going to go ahead and open up for Q&A for questions. And so we're going to give you a minute to enter some of your questions, and we're going to be more than happy to answer as many as we can. And it looks like we already have a couple in the queue right now. So I'm going to go ahead and start with Jason Piper. You're there, right, Jason? Yes, you are. So can you give an example of recent technology that you're using to help your facility in regards to using digital automation?
Sure, 100%. So going to kind of talk about two aspects. I'm going to talk about the compliance paperwork, but first I'm going to talk about as far as the unique position I'm kind of in to where it can get a little strategic. So I'm also over construction for Advent Health for the Mid-America region. So I'm doing a large project out south, and we're in the process of getting ready to start a master plan here at the main hospital. And that's remodeling our existing tower that's now 48 years old, 45 years old is where we're at. So what I'm doing is really embracing the BIM modeling to it, to where I'm going into existing floors, sticking the camera above ceiling. It's that scanner, and it scans the existing utilities that are there. We'll label it. So that's going to be unique to me as far as in the existing hospital, that I'm able to put stuff on a plan, hand it over to the facilities guys, so they're able to say, man, I can see the valves, I can see the fire smoke dampers, they're located on the drawing. So that kind of helps in that aspect. As far as the new construction that we're doing, fully BIM model capability of that, class detection, everything, to where they're able to, I can just turn the model over to them and they can exact match where all the compliance pieces are, air handling units, fire smoke dampers, VAVs, everything that we need to keep up to date on our compliance are going to be labeled in that BIM model, as well as we have our asset tag on it that will then tie into our work order system. So it's, for location wise, it's going to be a lot easier for them. So starting on the ground floor with that, pretty excited. The guys are excited. So a lot of the older guys in our staff aren't, because that's more of a computer thing, and this is clicking and buzzing around. So they're really not embracing it, but it's really getting us a good foothold for in the future. Second thing is, I know this isn't a plug, but using the Soleran app. With what we have here with Advent Health, we have an outrageous firewall trying to protect our patients' data. So I recently went out and bought a list of iPads that we're able and they're not tied into our network. I've got just individual cell coverage for them. So with our environmental cares, and when the guys are going out and doing their PMs, they take the pad with them, they take the picture, downloads everything, puts it in a file, and then we email it into our basically dispatcher, and we have a guy that's in charge of compliance here now, and he's able to download that directly into our electronic database for our compliance. So those are the two initiatives as far as assets on the electronic world and technology that we're using to embrace for compliance moving forward.
Great, thanks, Jason. Another question here, and this is going to be related to biomed. So we're going to pass this on to Damion. So Damion, how do you feel the question is, how is the biomed field changing their approach to adapting to constant changing technologies and software platforms?
That's a great question. Actually, I think it's evolved more in the last 5-6 years than it has probably the previous 20. Ultimately, many organizations have went the route of AeroScout, RTLS, tracking many of their devices, and many software platforms now offer integration into those, so that we don't have to work into two separate software programs. Same thing can be said for ICRI. There's also other softwares that can be integrated to notify of recalls and field service notifications. But beyond that, I believe the biomed world is very much becoming much more analytical. It's going back to the AEM, where we try to be identifying predictive type of maintenance, as well as doing risk assessments. In that same breath, to be good stewards of our organization's financial budget, to be able to validate return on investment, and also be able to speak on the vendors that are performing up to levels. So taking into effect items such as downtime, and also now entering costs associated to vendors, parts, and even your own manpower when entering work orders, can all lead up and paint a very clear picture whether items should be put under contract because of prolonged downtime, or if you should train your staff and take them off a contract because of prolonged downtime. Also, in that same breath, you can make a justification for a vendor or manufacturer that may not be living up to expectations based upon response time, as well as downtimes that may correlate with their ability to become on site or even receive parts. So I will say, very broad question, and there is very there's a lot of options out there to kind of dive a little bit deeper in. But overall, software is becoming much more integrated, and many of these maintenance databases provide the option to go in and go as deep down the rabbit hole as you would like. And at the same regard, I know that financial leaders are very interested on investments, and also want to ensure that they're maintaining accountability, which the AeroScout integration would come in handy, or making sure they're getting a return on investment, which the downtime and the tracking of costs would be a huge benefit compared to some of the older maintenance systems that have been out there for quite some time.
Yeah. Yeah. Well, I'm sure we can spend the rest this afternoon just talking on this. So.
Absolutely.
Okay. Well, we'll go ahead and we'll go on to our last question here. And I think I'm going to pass this one off to Jeff. And the question is, Jeff, do surveyors take into effect the circumstances regarding a hospital that has limited resources?
They do and they don't, Lance. As you know, that it's the job of a surveyor to assess the facility against the standard, especially in a deemed status survey, correct? And if you miss a few things on your inspections, or you miss a few things in your compliance program, we have to determine if those errors are standard level deficiency or a condition level deficiency, right? If it's a standard level deficiency, it's something that was just missed. It was not the result of understaffing. It was not the result of anything that was systematic or organizational in nature, but it was a mistake that was made. If it is a result of poor staffing or a retirement with a poor program to assure that knowledge of that person leaving was accounted for, and you run into bigger issues that are not isolated, but that are systemic, those then are condition level. And when I was with the Joint Commission, we would score those in the leadership chapter of the standards.
Yeah, exactly. Yeah, to be able to take that up to a higher level. Yeah, absolutely. So, okay, well, I think that's it for our questions for today. We're running out of time here, so we're at the end of today's topic. So first, I want to thank Jeff and Jason and Damion. Thank you for your time. This was all great information presented. I know we all benefited from. And one thing I want to have too with our speakers is our speakers are volunteering their time, and we're very appreciative of it because they're also wanting to see our network grow. So thank you, everybody, for your time today. A little bit of reminders is you're going to receive an email tomorrow with a link that'll have access to this webinar. And so we want to encourage you to share this information with your colleagues because we want to get them involved with our future webinars as well. as we were saying, we want to keep our network growing. So next webinar is going to be November 12th at 1 o'clock, and that's Central Standard Time. And the subject is going to be increasing compliance proficiency through digital automation. And so we've got some great speakers lined up for it already. And registration's open, and always, the registration's free at www.soleran.com/think tank. So we look forward to working with you again. And we want to encourage you to use Facility Compliance Think Tank Q&A in our group area on LinkedIn to get any additional questions answered by our industry experts, including the panelists that are here today. So we want to remind everyone that this is an area to interact with other professionals. So utilize this to your advantage, and utilize our panel experts as well, because we want to be able to share information at any time you may have a question. Well, that concludes today's webinar, excuse me. Soleran and our speakers, we want to thank you for joining us, and we look forward to seeing you in November. Thank you, everyone.